guys. Chapter 8, Lifting and Moving Patients. EMS operations is going to be the knowledge of operational roles and responsibilities to ensure patient, public, and personnel safety. In the course of a call, you will have to move patients to provide emergency medical care and transport. To move patients without injury, you need to learn the proper techniques. Knowledge of proper body mechanics and a power grip is important. The wheeled ambulance stretcher, also called an ambulance stretcher or gurney, is the most commonly used device. The wheeled ambulance stretcher weighs 40 to 145 pounds, generally not taken up or down stairs or where the patient must be carried for any significant distance. Moving a patient by rolling, using a stretcher or other wheeled device is preferred when the situation allows and helps prevent injuries from carrying. A number of models are available, and before going on a call, you should familiarize yourself with the specific features of the stretcher your ambulance carries. And for us, the good thing is all of our stretchers are the same. General features is the head end and the foot end, strong metal frame to which all parts are attached. The hinges at the center allow for elevation of the head and the feet, and the guardrails prevent the patient from rolling out. Undercarriage frame allows adjustment to any height, and the mattress is fluid resistant. They are required to be fluid resistant. The patient is secured with straps, and that helps protect the patient from any further injury. This is a backboard, a long, flat, and made of rigid rectangular material, mostly plastic. Some people also call these longboards or spine boards. Most commonly, the term is backboard. Used to carry and immobilize patients with suspected spinal trauma or other trauma. They're commonly used for patients found lying down. They're used to move patients out of those awkward places, such between the toilet and the tub, or beside the bed and the wall. They are normally 6 to 7 feet long, and the holes serve as handles and also a place to secure straps. When you move a patient, take care that injury does not occur to you, your team, or to the patient. Patient lifting and moving are technical skills that require repeated training and practice. Many EMTs are injured during lifting and moving patients, and using proper body mechanics and maintaining physical fitness greatly reduce the chance of injury. So y'all will be doing some moving and lifting skills in class. It'll make more sense to you then, maybe. Body mechanics. Here's you a diagram. I'm sure it's in your book. It's in an anatomy review. Lifting patients, you're going to keep your shoulder girdle aligned over your pelvis. You're going to make sure your hands are held close to the legs, and then force then goes essentially straight down your spinal column, and very little strain occurs when you're lifting in the proper manner. This is the correct way to lift. There's a diagram there. It shows you. It's also in your book. But that is actually what you should look like when you're preparing to lift a patient. You may injure your back if you lift while leaning forward, and you lift with your back straight but bent significantly forward at the hips. This is an incorrect method of lifting. Lifting technique. Legs should be spread about 15 inches apart, which is basically your shoulder width. You're going to place your feet so that the center of gravity is balanced. And with your back held upright, you're going to bring your upper body down by bending the legs. You're going to grasp the patient / the stretcher. You're going to lift the patient by raising your upper body and arms and straightening your legs until standing. You're going to keep the weight close to your body and keep your arms the same distance apart. Power grip. It gets maximum force from the hands. Your palms would be up, your hands about 10 inches apart. All of your fingers are going to be at the same angle, and you're going to fully support handle on the curved palm. When directly lifting a patient, tightly grip the patient in a place and manner that will ensure that you will not lose your grip on this patient. Body drag. The same body mechanics and principles apply to moving, lifting, and carrying a patient. You're going to keep your back locked by tightening your abdominal muscles. You're going to kneel. You're going to extend your arms no more than 15 to 20 inches in front of you. Alternate between pulling the patient by flexing your arms and repositioning yourself. There's an example. To drag a patient across a bed, you're going to kneel on the bed to avoid reaching beyond the recommended distance. You're going to drag the patient to within 15 to 20 inches. Then you're going to complete the drag while standing at the side of the bed. You're going to use the sheet or blanket under the patient rather than dragging the patient by his or her clothing. In the hospital, transfer the patient from the stretcher to a bed with a body drag. The stretcher should be the same height or slightly higher than the bed. You and your partner should kneel on the bed and drag in increments. Log roll the patient onto his or her side to place a patient on a backboard. Kneel as close to the patient's side as possible. You're going to keep your back straight and lean solely from your hips. Roll the patient without stopping until the patient is resting on his or her side and braced against your thighs. Pulling toward you allows your legs to prevent the patient from rolling completely over. Whenever possible, use a device that can be rolled. When a wheeled device is not available, make sure that you understand and follow the guidelines for carrying a patient on a stretcher. Patient weight. Estimate the patient's weight before lifting. Adults often weigh 120 to 220, but 2 EMTs should be able to safely lift this weight. Try to use 4 providers to lift when possible. More stability requires less strength. Do not attempt to lift a patient who weighs more than 250 pounds with fewer than 4 providers. Know the weight limitations of the equipment and how to handle patients who exceed the weight limitations. Important thing, guys, is to know what your limitations are and never push yourself beyond your limitations. Because if you're hurt, you can't take care of somebody else. Lifting and carrying a patient on a backboard or a stretcher, more of the patient's weight rests on the head half of the device than on the foot half. The diamond carry and the one-handed carry use 1 EMT at the head and 1 at the foot and 1 on each side of the torso. So 4 people. And there's your example. Lifting and carrying a patient on a backboard or stretcher, use 4 providers, 1 provider on each corner of the stretcher to provide an even lift. When rolling the wheeled ambulance stretcher, make sure that it is fully elevated position. Your partner should control the head end and assist you by pushing with his or her arms held with the elbows bent. Moving a patient with a stair chair. You're going to use a stair chair to carry a conscious patient up or down a flight of stairs. The lightweight wheeled folding chair has a molded seat, adjustable safety straps, and fold-out handles at both the head and the feet. A backboard should be used instead for a patient who is unresponsive, who must be moved in the supine position, and who must be immobilized. Carry the patient on the backboard down to the prepared stretcher. Place the strongest EMTs at the head and the foot ends. with the taller person at the foot end. Place both the backboard and the patient on the stretcher. Secure both to the stretcher with additional straps. Loading a wheeled stretcher into an ambulance. Ensure the frame is held firmly between two hands so it does not tip. Newer models are self-loading, allowing you to push the stretcher into the ambulance. Other models need to be lowered and lifted to the height of the floor of the ambulance, and there's clamps in the ambulance to hold the stretcher in. Team actions must be coordinated. Team leader indicates where each team member should be and rapidly describes the sequence of steps to perform before lifting. Preparatory commands are used. Example, team leader says, all ready to stop to get the team's attention. And then the team leader says stop in a really loud voice. Countdowns are also used, such as we're going to move on the count of 3. We're gonna lift this patient after we say 3 or on the count of 3. Carefully plan ahead. Select the methods that will involve the least amount of lifting and carrying. Consider whether there is an option that will cause less strain. Emergency moves. You're going to use when there is a potential for danger, such as fire, explosives, hazardous materials. And you're also going to use when you cannot properly assess the patient or provide immediate care because of the patient's location or position. If you're alone, you're going to use a drag to pull the patient along the long axis of the body, and you're going to use techniques to help prevent aggravation of patient spinal injury. You got the clothes drag, the blanket drag, the arm drag, or the arm-to-arm drag. Here's your examples of your clothes drag, your blanket drag, your arm-to-arm, and your arm drag, or whatever it was. To remove an unconscious patient from a vehicle alone, we're going to move the patient's legs clear of the pedals. We're going to rotate the patient so the back is toward the open car door. You're going to place your arms through the patient's armpits and support the head against your body. Then you're going to drag the patient from the seat to a safe location. Here's examples. Urgent moves. Necessary to move the patient with altered level of consciousness, with inadequate ventilation, in shock, or in extreme weather conditions. Rapid extrication technique requires a team of knowledgeable EMTs. Rapid extrication technique should be used only if urgency exists. The patient can be moved within 1 minute, so an urgent move has to be completed within 60 seconds. If you can't complete it within 60 seconds, you do not do it. This technique increases the risk of damage if the patient has a spinal injury, and you are going to look at all options before using any urgent moves. Non-urgent moves are used when both the scene and the patient are stable. Carefully plan how to move the patient. Your team leader should plan the move. They should figure out the personnel, identify any obstacles, have all the equipment together, and make sure they have the procedure and the path of moving the patient down before anyone ever begins to move the patient. You're going to choose between a direct ground lift for patients with no suspected spinal injury who are supine, patients who need to be carried over some distance, and EMTs stand side by side to lift and carry the patients. Extremity lift for those patients with no suspected spinal injury who are supine or sitting. Helpful with the EMT is in a small space. One EMT is at the patient's head and the other is at the patient's feet. and coordinate and moves verbally. So you're going to coordinate with each other and you're going to move at the same time. Transfer moves, you've got the direct carry, which you move supine patient from a bed to a stretcher using a direct carry method. Draw sheet method is just that. It's when you move the patient from the bed to the stretcher using a sheet or a blanket, and then scoop stretcher. Most patients transported by EMS are geriatric patients. Skeletal changes may cause brittle bones, rigidity, and spinal curvatures that present special challenges. Allay the patient's fears with sympathetic and compassionate approach. Here you have a patient that has kyphosis and spondylosis, and as you can see, you could not lay that patient flat on a spine board. I mean, you can't technically even lay them flat on a stretcher. So basically, you have to place them in the position of comfort of how you can get that patient. Bariatrics refers to the management of obesity. 76 million U.S. adults are obese. 30 to 40% of adults are obese, and approximately 17% of children. Back injuries account for the largest number of missed days of work for EMTs. Stretchers and equipment are being produced with higher capacities. It does not address the danger to the users of that equipment, and mechanical ambulance lifts are uncommon in the United States. Bariatric stretchers specialize for overweight or obese patients. They have a wider wheelbase for increased stability. Some have a tow package with a winch, and they're rated to hold 850 to 900 pounds. A regular stretcher is rated for 650 pounds max. Pneumatic and electronic powered wheel stretchers, battery operated with electronic controls to raise and lower the undercarriage, increases the weight of the stretcher, and it's hazardous and in uneven terrain. These are like our stretchers. That's an example of the pneumatic and electronic powered wheel stretchers. Portable folding stretchers. This is strong rectangular tubular metal frame with fabric stretched across it. Basically, those are like the little stretchers that you used to see in war movies. Got the 4 handles, 4 grips. Some models have 2 wheels. Some can be folded in half. They're used in difficult to reach areas and they weigh less than wheeled stretchers. A flexible stretcher is excellent for storage and carrying. They can form around a patient's sides. Useful for confined spaces. They're uncomfortable but provide support and immobilization. Okay, a short backboard. Example of a short backboard is a KED. It's a Kendrick extrication device. It's used to immobilize seated patients, more commonly used in MVAs. Um, I don't know if any of you have used one, but we will do that in class. But it secures the head, holds C-spine, and you have straps that it secure it to the upper torso. And so basically you have a backboard from the patient's waist up to the top of their head where it secures and immobilizes their head. And we will use one of those in class to make you familiar with that. Vacuum mattresses. It's an alternative to backboards for immobilizing geriatric and pediatric patients. The air is removed from the device, allowing it to mold around the patient. It provides immobilization, comfort, and thermal insulation. Basket stretchers. They're also known as a rigid stretcher. They're also called a Stokes leader or a Stokes basket. They're used for patient removal in remote locations, including in-water rescues and technical rope rescues. Basket stretchers, if the patient has a spinal injury, secure the patient to a backboard and then place inside the basket stretcher to carry the patient out. When you return to the ambulance, lift the backboard out of the basket stretcher and place on the wheeled stretcher. There's an example of a scoop stretcher, also called orthopedic stretcher. Now, on those, they split down, like the ends come open, so it actually is two halves, and then you reconnect it back under the patient. Um, they used to be used, I would say, more common than now, but they still are used now, just not as much. It splits into two or four pieces. Pieces fit around the patient, and then you reconnect them. Both sides of the patient must be accessible to use it, and the patient must be stabilized and secured on a scooter. Neonatal isolate, sometimes called an incubator. Neonates cannot be transported on a wheeled stretcher. The isolate keeps the neonate warm and protects the child from noise, draft, infection, and excess handling. The isolate may be secured to a wheeled ambulance stretcher or freestanding. Decontamination. You should decontaminate equipment after every use for your safety, for the safety of the oncoming crew, for the safety of the patient, and then to prevent the spread of disease. Patient positioning. Proper patient positioning depends on the chief complaint. Patients with head injury, shock, spinal injury, pregnancy, and obese patients need special lifting and moving techniques. A patient reporting chest pain or respiratory distress should be placed in a position of comfort, typically a Fowler or semi-Fowler position. Patients in shock should be placed in a supine position. Patients in late stages of pregnancy should be positioned and transported on their left side. An unresponsive patient with no suspected spinal injury should be placed in the recovery position. And if you are listening to this lecture, then if you will text me the recovery position, what side you lay the patient on in the recovery position, you will get a bonus point. A patient who is nauseated or vomiting should be transported to a position of comfort, in a position of comfort. Obese patients should be positioned the same as other patients with similar conditions. Medical restraints, you're going to evaluate for correctable causes of combativeness, such as head injury, hypoxia, or hypoglycemia. You're going to follow your local protocols. Your restraint requires 5 personnel. Technically, you should have one for the head, one for each extremity. You're going to restrain the patient in a supine position because of positional asphyxia may develop in the prone position. Um, you're going to call medical control for orders for restraints. You never restrain without medical orders from the doctor. Apply a restraint to each extremity. You're going to assess the ABCs, mental status, and distal circulation after restraints are applied. You're going to document all information. Personnel considerations. Questions to ask before moving a patient. Am I physically strong enough to lift or move this patient? Is there adequate room to get the proper stance to lift the patient? Do I need additional personnel for lifting assistance? And always remember that injured EMTs cannot help anyone else. This concludes Chapter 8, Lifting and Moving. Don't forget, if you listened and you heard the bonus question, text it to me for 1 bonus point. You get 1 bonus point if you text me the answer.